Welcome to the MRCpology channel for a quick review and understanding of the topic. Imagine a patient suddenly develops the worst headache of their life during exercise, reaches maximum intensity almost immediately, vomits, and briefly collapses. In the MRCP exam, that is a dangerous headache until proven otherwise. A thunderclap headache means a sudden, maximal intensity headache that reaches peak severity within seconds or in less than 1 minute. The key principle is simple. Treat thunderclap headache as subarachnoid hemorrhage until proven otherwise. To understand this topic, think in 3 boxes: vascular bleeding, vascular narrowing or blockage, and pressure-related causes. The most important cause is aneurysmal subarachnoid hemorrhage. An intracranial aneurysm ruptures, arterial blood enters the subarachnoid space, and that blood irritates the meninges. This causes explosive pain, often with vomiting, meningism, collapse, reduced consciousness, or seizures. Raised intracranial pressure may add to the severity. Another important cause is reversible cerebral vasoconstriction syndrome. Here, the cerebral arteries undergo transient multifocal vasospasm. The clue is recurrent thunderclap headaches, often triggered by exertion, sex, the postpartum state, or serotonergic and sympathomimetic drugs. MRCP trap: recurrent thunderclap headaches are not automatically benign migraine. Think of reversible cerebral vasoconstriction syndrome. Cervical artery dissection is another dangerous mimic. An intimal tear in the carotid or vertebral artery leads to a mural hematoma. This can produce sudden head or neck pain and may later cause embolic stroke. Neck pain, focal neurology, or headache after minor trauma should raise suspicion. Cerebral venous sinus thrombosis causes thunderclap headache by a different mechanism. Venous drainage is impaired, venous pressure rises, intracranial pressure rises, and the patient develops severe headache. Papilledema, seizures, pregnancy, postpartum state, dehydration, thrombophilia, or anticoagulation issues should make you think of venous thrombosis. Pituitary apoplexy is another classic exam diagnosis. Hemorrhage or infarction occurs inside a pituitary adenoma, causing sudden severe headache with visual field defects, ophthalmoplegia, or ocular motor palsies. The key clue is thunderclap headache plus visual or eye movement disturbance. Other causes to keep in mind include intracerebral hemorrhage, meningitis, posterior reversible encephalopathy syndrome, and spontaneous intracranial hypotension. The main message is that primary thunderclap headache is a diagnosis of exclusion. Now let us connect the mechanism to the clinical features. Sudden arterial bleeding irritates the meninges, so patients develop severe headache, neck stiffness, photophobia, and vomiting. Raised intracranial pressure explains collapse, reduced consciousness, papilledema, and sixth nerve palsy if present. Cortical irritation explains seizures. Focal neurology suggests local brain injury, dissection with stroke, hemorrhage, venous thrombosis, or a structural complication. The red flags are collapse or syncope, vomiting, meningism, reduced consciousness, seizure, focal neurological signs, papilledema, neck pain, pregnancy or postpartum state, anticoagulation, and onset during exertion or sexual activity. These features should push you towards urgent investigation rather than reassurance. The first investigation is an immediate non-contrast CT head. This is the emergency test to look for subarachnoid hemorrhage and other intracranial bleeding. If the CT is negative but clinical suspicion remains, lumbar puncture is needed after appropriate timing to look for xanthochromia and red blood cells. Timing matters because xanthochromia takes time to develop, so a very early lumbar puncture may be misleading. Further vascular imaging depends on the suspected diagnosis. CT angiography or MR angiography can look for aneurysm, reversible vasoconstriction, or arterial dissection. CT venography or MR venography is used when cerebral venous sinus thrombosis is suspected. The investigation should follow the clinical clue: aneurysmal pattern, recurrent triggered thunderclaps, neck pain with possible dissection, postpartum or prothrombotic state, papilledema, seizures, or visual symptoms. Initial management is urgent. The patient needs emergency department and neurology or neurosurgical assessment, analgesia, antiemetics, monitoring, and careful blood pressure control if hemorrhage is suspected. The exact treatment depends on the underlying cause, but the first step is not to label it as migraine or primary headache too early. MRCP trap: a normal neurological examination does not exclude subarachnoid hemorrhage. Another trap: thunderclap headache after sex or exertion still needs secondary causes excluded. Another trap: Recurrent thunderclaps suggest reversible cerebral vasoconstriction syndrome, but subarachnoid hemorrhage and vascular dissection still need consideration. If you remember one thing, remember this. Thunderclap headache is sudden, maximal, and dangerous. Investigate urgently, exclude subarachnoid hemorrhage first, and do not diagnose primary thunderclap headache until secondary causes have been excluded. Quick recall. A patient develops a sudden worst-ever headache during exertion, vomits, and has neck stiffness, but the initial non-contrast CT head is negative and clinical suspicion remains high. What is the next important investigation, and what are you looking for? The answer is lumbar puncture after appropriate timing, looking for xanthochromia and red blood cells to support subarachnoid hemorrhage. A postpartum patient has recurrent thunderclap headaches triggered by exertion, with vascular imaging showing multifocal narrowing of cerebral arteries. What diagnosis does this suggest, and what is the key mechanism? The answer is reversible cerebral vasoconstriction syndrome caused by transient multifocal cerebral arterial vasospasm. Do subscribe to the channel for further videos.